Well, hello everybody and welcome to another HERO webinar. I'm Paul Terry. I'll be your host as usual. And today on the screen, you'll see I'm about to introduce Tanya Odom and Eduardo Sanchez, two real leaders in something that a lot of you trained in public health in particular are being reminded of this past year, in particular that term syndemic. What you remember, if you were formerly trained in public health, that pandemics are bad enough, but when two epidemics occur at the same time, we call that a syndemic. And in our country, we've been suffering under a long year of COVID-19. And perhaps not coincidentally, it's been a year in which racism and racial discord and health disparities have also been raging throughout the nation. So to help us think through and address and call to action related to this syndemic, we couldn't be in better hands. The title of our presentation today is Structural Racism as a Driver of Health Disparities. And again, Boyd, you have two super smart, committed professionals who know exactly what's at stake in terms of us getting this right and taking advantage of this moment. Before I do that, there is pretty keen overlap between the topic that we're tackling today and the very issues that we intend to tackle at HERO Forum 2021. We think most of you are going to be able to come live. The vaccine rates, what they are, and the trends. Our president just called June a call to action month as well, in terms of us really getting up to our 70% goal for vaccination. So there's no reason why you can't join us in Austin, Texas, although a reminder that this will be a hybrid conference. So if you can't come live, we certainly have lots available for you in a hybrid sort of way. We're calling this theme Bouncing Back, boosting mental resilience and building organizational immunity. And you'll see as you look at this agenda that this syndemic is front and center in terms of what we're going to be talking about. So do mark your calendar for that week of October 11th, and we'll see you in Austin, Texas. And we hope to see our presenters today. Tanya Odom has been working in the health disparities field most of her career. She's a global consultant, coaching, focus on well-being and leadership coaching. If you look at her LinkedIn page, you'll see that she's very active in most currently reminding us about the Tulsa race massacre and the 100-year commemoration of that work. She's been a consultant to many agencies in the United Nations. She's been a consultant for UNICEF. You can find her most recent gig by going over the Walton Family Foundation page, and you'll see that she is also the Equity and Inclusion Program Director. I can't get through all of this bio, Tanya, but I simply would say you've been in the belly of the beast in a syndemic for many years. So thank you for your hard work. You'll see if you look at her background that she's master's trained at Harvard University. She's an anthropology expert from Vassar College. So as I said, we're in terrifically good hands today. And her partner for today's presentation is Eduardo Sanchez. You can see that he's got more letters than I can reiterate in a short period of time, but he has been the Chief Medical Officer for the American Heart Association. Before that, he was VP and CMO for Blue Cross Blue Shield of Texas. He's been on lots of boards and committees throughout the nation. Eduardo, I was especially interested to see you were the chair of the advisory committee to the director at the CDC at a time when things couldn't have been more volatile at CDC. So this is not your first crisis to wade through on behalf of the nation. And then you all should know, as we talk about the elephant in the room, the big ideological differences between Republicans and Democrats on issues that we're about to talk about. Eduardo, you were the Commissioner of Health in the great state of Texas. So you are no newcomer to wading in deep into politically polarizing issues. For folks who don't know Eduardo, do just scroll through his many web pages of accomplishments. One of the things that I just got such a kick out of that I stopped and I couldn't get through all of it in advance of this presentation, but Eduardo, almost a year ago to this month, was with Senator Frist on a rather long interview about the COVID-19 pandemic right at the outset. And you were just downright prescient, Eduardo, in terms of naming the comorbidity issues, naming the things that are going to create disparities in our nation. So do all dial into that and see how far we've come. Eduardo was quick to point out your role, Tanya, as a board member for the American Heart Association. He said you were the chief agitator to get the AHA to really get after this. And so congratulations to both of you. You're obviously a fantastic team. Ariane, I'm going to stop sharing there so you can get their presentation up and ready. As always, you guys, we're going to be watching the Q&A box. So as they're presenting in the first 20 minutes, don't hesitate to start in with your questions. We'll address them right away if they seem relevant, or we're going to hold them obviously in Q&A time. As always, we'll have polls right in the presentation and certainly shortly thereafter. And Ariane, I think you and Tanya and Eduardo were intent on getting a poll up right off the bat, so we could just set the tone and hear what our participants throughout the nation are thinking about. So this one simply asks, where is your organization in the journey of addressing structural racism? You know the drill. Those of you who have been on Hero webinars, don't come into our Q&A box, go over and specifically tap on that poll question itself. And Ariane, we're tracking fairly quickly, and I think already we're seeing a relatively apparent trend. We're going to give it just a second before we launch the results. But I think the trends are kind of apparent already, Ariane. So why don't you go ahead and stop that poll and share those results, just to give Tanya and Eduardo a preview of what people around the country are saying. And Tanya, let me start with you. Are you seeing the results?
I saw them. What I saw was 50-50.
Yeah, exactly. 50% saying we've started discussing it, 50% saying we've been discussing it and have plans and strategy to actually address it. There's nobody, at least in today's audience, that says we've not been discussing this issue. Any reaction, surprises, Tanya?
No, the consultant brain in me has a dozen more questions I would ask then, in terms of who's involved, leadership engagement, and all those things we know that will make it successful, which I think will come out in some of our conversations.
Absolutely, we'll be asking just those questions. So Eduardo, I think you've got the first few slides, so I'm going to turn it over to you. And again, thank you for joining us today.
Well, before we go to the first slide, let me just set some things up. Thank you so very much, all of y'all, for being a part of this discussion that we're about to have. I do want to say, so I do work for the American Heart Association. We have the greatest mission statement ever, one, I can remember it, and actually am pleased to keep saying it. And it's to be a relentless force for a world of longer, healthier lives. And implicit in that is a commitment to health equity and the elimination of health disparities so that those longer, healthier lives are equitably shared and equitably enjoyed. At the same time, ours is an organization that is going to be 100 years old in 3 years. And it's an organization whose commitment started around the same objective of longer, healthier lives, not quite articulated that way, but really through kind of a bioscience frame. Research, medical research, clinical interventions that has taken us upstream through a path that I'm going to talk a little bit more about, but that landed us at a place even before COVID that began to wonder about the role that structural racism might be playing in what are health disparities that we still witness and watch, but that were in many ways accentuated by COVID-19, in that the disproportionality of COVID-19 exposed both on the social determinants of health side and with regards to the higher infection rates of some compared to others, and then the burden of disease also being a reflection of not only race, ethnicity, but also likelihood of severe or fatal COVID. That, in combination with the very public, callous murder of George Floyd and many others who died in the course of the last 15 to 18 months, and even before that, at the hands of police, what had started as a process of discussion and discovery and discussion was accelerated and catalyzed and resulted in, next slide, the publication in November, after starting a process to put a paper together that is this call to action: structural racism as a fundamental driver of health disparities. Tanya Odom and I are, along with a host of superstars and super thinkers among the writing group that started its work in August of 2020. First Sunday in August, we had a draft, a pretty much a final draft by the last Friday of August, because all of us had been thinking about these issues for a good while, and we were able to coalesce. We hadn't been talking to one another about it, but we'd all been thinking about it in our own realms. And a presidential advisory is sort of the pinnacle of statements from the American Heart Association. So I'm going to stop there. I'll be back. I'm going to hand off to Tanya, and we're going to keep going sort of back and forth on this. Tanya.
Thank you, Eduardo. So we can go to the next slide. I think one of the things when we think about this paper that we wrote, there are a couple of things that I also want to highlight that many of us know should not be taken for granted. One was the diversity of people who came together to write this paper. This was a science paper by structure, but we brought in people like myself who work in the space that deal with issues and talk about issues and research issues of structural racism. We also made sure that, in fact, things like the citations that we had represented a diversity of experiences and backgrounds, knowing the research on how sometimes even implicit bias can sneak up into things like who gets cited. But here you see the summary, and I won't sort of go into everything in the abstract summary, but a couple of things I think are really important. And this comes, Eduardo will give you the sort of doctor part of this, but this notion of really acknowledging and naming the fact that structural racism contributes to the disproportionate burden of cardiovascular risk factors. I think that's important. Also, when we think about this, and this second bullet to me is so incredibly important to the work of AHA, but just to any organization, that when you look at structural racism, Dr. Tricia Rose at Brown talked about cogs in a wheel. Sort of they're connected cogs that are connected to each other and impact each other. And so this second bullet point talks about that structural racism is manifest in current systems and laws related to housing, education, criminal justice, health and healthcare, and economic opportunities. And we were really intentional in the paper of naming and talking about all of those things in relationship to the health disparities. And then I think for me as a volunteer for AHA for many years, the thing that was really important was that, again, this sort of naming and centering the fact that structural racism is a significant impediment to the goal to equitably achieve cardiovascular health for all people. It's one thing to sort of say this is one of the variables, but to really talk about the significance of structural racism in reaching the goals of American Heart Association. Next slide, please. So here's something that some of you may have seen, which I think is really important, and you'll hear me talk about this at the end too. Really, when you talk about this work, so I've been in this space of equity, diversity, inclusion, and civil rights for 25 years. There tends to be this very specific, often narrow perspective that we're talking about individual or personal racism or bias. So you think Tanya's racist, you think Tanya's biased, therefore we need to look at Tanya as an individual, rather than the structures and systems that have these sort of biases and inequities embedded within them. In fact, there's some research on racism that talks about one of the impediments to addressing some of these issues of racism is an ahistorical analysis, is not looking at things like, for example, I read something today about, from Brookings, I think it was, about the impact of the Tulsa race massacre on something like, which you'll see us talk about, on something like the Black-white race wealth gap, right? So how do we look at these things from a very particular perspective? And I think what you heard Paul talk about in terms of my pushing to make sure that we were acknowledging the disparate impact of COVID-19 on communities of color, particularly Black, Brown, and Indigenous communities, was the fact that what we were hearing in the media oftentimes were just data points of, comorbidities or disparate impact, which kind of left many people to the conclusion, perhaps, or biases, that these weren't institutional or structural issues that were impacting sort of who was dying, who was getting sick, but really that they were individual and personal. And I think I'll say this last thing before turning it back to Eduardo, that for me, one of the biggest shifts that I've seen in the last year when we've seen the sort of increased focus on racial injustice has been a greater awareness of the importance of looking at structural racism, in this case for health disparities, but just in general. So Eduardo, I'll turn it back to you.
Thanks. Let's go to the next slide. So as Tanya said, now I'm going to walk you through the science lesson. And, one of the things that I'm going to remind you of, I mentioned earlier, AHA is about 100 years old. In 1924, a handful of cardiologists came together and said, we got to do something about heart disease that is killing people and figure out what we do. And in the course of many years, we're an organization that's known for being the organization that has not only supported the science, but translated the science of resuscitation. So basic life support, the things that happen when EMS comes to a site and resuscitates somebody, what happens in the hospital when someone's heart stops beating, that was informed by the American Heart Association. The American Heart Association is now the American Heart Association, American Stroke Association. And whether we're talking about heart attacks, strokes, exacerbation, that is a worsening of heart failure, when you end up in the hospital, the things that are done are based on the science. It's been translated into guidelines that say when somebody who's 40 years old and has the following background and comes in with a heart attack, here are the things you do. If they're 70 years old, here's what you do. If they're female, you do this. If they're male, you might do something different. And we are also the organization that informs what happens in primary care and ambulatory care settings at the family physician's office, the internist's office, the cardiologist's office, or the neurologist's office, taking care of people who are not in the hospital. So having said all that, we're all about that science about clinical care. And we track things like who dies of what. In this country in 2019, number one cause of death was heart disease. Number two cause of death was stroke. I will tell you right now that in 2020, you probably can imagine, the number two cause of death, counting from January to January, was COVID-19. Stroke dropped to number 6. But in general, about 800,000 people a year are dying due to heart disease and stroke. Next slide. Now, one of the things that I find and have found so striking are visualizations of statistics. And what you are looking at here, because I'm not going to bore you, you see 5 columns. And what those 5 columns are showing is the adjusted total cardiovascular disease mortality rate by race and ethnicity, or ethnicity, frankly, actually, across these 5 groupings. And what I want your eyes to notice is that the line that is the highest up is the line for non-Hispanic Black persons. That line represents or suggests or points out that the mortality rate for non-Hispanic Blacks is higher than that for others. And what I also want you to see is that this is supposed to represent the trajectory of this statistic over actually an 11-year period. Well, you can see they all go down. That's fantastic. But what I want to point out is that at its lowest point, African-American person death rate at its lowest point doesn't even begin to reach the highest level a decade earlier for the other 4 groups that are represented here. That begs the question, why? And that begs the question, what do we need to do to eliminate that variability? This is cardiovascular disease mortality rate. Let me show you stroke mortality rate. Next slide. And what you may think to yourself is, well, same lines. Well, they're not quite the same, except they show the same thing. And in fact, it's even more stark, I think, when you look at stroke. That is, and not only is the rate also higher at all levels, but for non-Hispanic Black persons, there's an uptake in the age-adjusted stroke mortality rate. That's why the line kind of curves back up. That's not a good thing to curve back up. It does so among a couple of other groups as well. But the main point is that there's this disparity in mortality that begs the question why, and begs the question, what do we do about it? Next slide. Now, mortality rates are not the only way to look at disparity. And I'm going to focus in for the next couple of slides here for the next few minutes on blood pressure control. Now, blood pressure control is really important because blood pressure that's too high contributes to heart attacks that can be prevented, contributes to strokes that can be prevented, contributes to heart failure that can be better controlled, all of which contributes to higher mortality. So I'm going to point out a few things on each of these little graphs. I think I've got 3 of them. First of all, when you look at the 4 bullets, the 4 lines that have race, ethnicity, non-Hispanic, white, Black, Asian, and Hispanic, what I want you to see is that non-Hispanic white person prevalence of blood pressure control, 48%. The higher the number, the higher the control, the better that is. Now, 48% is nothing to brag about. It should be at 70%. It should be at 80%, but it's close to 50%. What I want you to see is that for non-Hispanic Black, non-Hispanic Asian, and Hispanic patients who have high blood pressure, that level is closer to 40%. And when you multiply that percentage by the millions of people we're talking about, there is a unacceptable disproportionality in blood pressure control rates. Other place at the bottom of this table, what I want you to see is that if you don't have health insurance, blood pressure control 24% compared to more than 40% if you have any kind of health insurance. And last, and the really important one that I want to point out is that if you've not seen a healthcare provider in the past year, blood pressure control, if you have high blood pressure, is only at 8%. When it's only at 8%, it increases the chance of a heart attack, of a stroke, of heart failure, and premature death. Next slide. So this looks at a different set of factors that I think are important. And I point these out because the factors before are they might be patient factors that are phenotypic. You might look at them and determine what they are, or ask about race, ethnicity if you're not certain. And then whether you've seen a healthcare provider or not might fall into a category that has to do with medical care. But here are some factors, as you know, these are socioeconomic factors. They are among the social determinants of health. And what I want you to see, because I put it in red, is that if you've not graduated from high school, your blood pressure control rate is much lower than if you've had high school and some college, which is lower than if you've had some college education. And when you look at income, again, the lower your income, the lower the level of control for blood pressure, for having hypertension diagnosed. Next slide. So now I'm moving to life expectancy, because I talked about mortality, and you could see that for cardiovascular disease and stroke, mortality is higher among African-American persons than virtually everyone else. I talked a little bit about race, ethnicity, and the disparity in blood pressure control and some socioeconomic factors, but let me finish my little part here and point out that when we look at life expectancy as defined in 2019, life expectancy for non-Hispanic Black persons in the United States, 75 years. And for non-Hispanic white persons, 79 years. For Hispanic persons, it's over 80 years. There are gaps, particularly the gap between Black non-Hispanic persons and whites and Hispanic persons is stark. And again, it begs the question, why is that? And it begs the question, what can we do about it? So I'm going to pass this off to Tanya. We'll continue this story.
Thanks. Next slide, please.
As we transition, Eduardo, between science, and I know Tanya's going to start talking about the social science again. In your honor, I took my Omron out and did my blood pressure measurement while you were talking. I'm usually comfortably under 120/70. I think you're getting me so excited on this topic. I came in at 132/75. So thanks a lot, dude, for getting my blood pressure up. But while we transition to Tanya, on the science side, let me ask you, as people are responding to Tanya's question about have the outside world incidents, anti-Asian violence, George Floyd's murder, impact the dialogue internally in your organization? And I'll launch that response in just a second. Eduardo, could you summarize the science by answering whether or not racism, as distinct from race or socioeconomic issues, racism can raise my blood pressure. Racism can create hypertension.
Tanya's given the answer by nodding. Absolutely. So racism creates a situation where you are experiencing chronic stress. And without going into a lot of the detail, chronic stress equals stimulation of some of the wrong things. Paul, your blood pressure went up a little bit, perhaps due to what you were hearing. That's maybe acute stress. This is not a simple or easy topic to talk about. So excited might be one word, nervous, anxious, apprehensive might be another way, because none of this is simple to talk about. I think Tanya and I would both agree that one of the things you've got to have some degree of comfort is that it's uncomfortable to talk about this, no matter where you're talking about it from, whether you're coming from a place of righteousness or you're coming from a place of defensiveness. It's not an easy thing to talk about, but experiencing it every day, you walk out the door and that's your life. I don't need to describe it. Others have described what it's like to drive through a neighborhood and know that if you get stopped by a policeman, it may be different than if someone else gets stopped. That causes chronic stress. That can increase blood pressure and other things. Great question. I hope that answer was satisfactory.
Yeah, thank you for that. And Tanya, here are your results. Pretty resounding yes to this. Outside world incidents are absolutely impacting our dialogue in the workplace. So back to you.
Yeah, no, thank you. And I think it actually connects. I really appreciate your question about racism. And I think Eduardo can talk to the increase in science, but just as a social science person, we're seeing a lot more data come out talking about the why, right? Talking about the impact of microaggressions, of blatant racism on people's health. So I think I mentioned this a little bit, but here you see the median net worth. And these statistics, I think you're seeing discussed more because this, in fact, is generational oftentimes, right? This isn't just sort of how we can look at this one moment in time. This is saying if we look at white non-Hispanic versus Black versus Hispanic, we can look at obviously a huge gap in terms of the wealth gap by race. And I think there's more of a focus on this. There's some actual interesting research being done and looked at around the tax system and how the tax system supports or doesn't support this. I think this could be a whole session in itself. Next slide, please. So when we look at this, I think Eduardo talked about this and we've said this, but really I think it's important to just focus on the systemic nature of interlocking systems and the way in which we live our life, the experiences of what structures. I was in grad school, I'll never forget, and Mel King, who's a civil rights icon and legend, went through this activity where he said, put yourself in the name in the middle of a circle and then talk about all of the systems that have impacted you up until this date. Now, I remember sitting there really thinking about this question and talking to him as someone who's been involved in civil rights for decades on what a brilliant question that was for people to think about, because it asks us to assess how some of these systems either did or didn't impact us. Did we have access? Did we were able to get healthcare? All of these different things. And for me, I think this last piece is really important, that there's an interplay, that it's not one thing or the other. We know in the United States, a connection between education and housing, right? And where people live and how they could afford to live in a place is there. And also between the social determinants of health, race, and health outcomes. So I'm going to turn it back to you, Eduardo, for one next slide, and then I'll come right back.
So next slide. I want to focus on the slide for a moment because I think it's critically important for a variety of reasons. One is that let me just do an advertisement on behalf of Tanya and myself and the other co-authors. Please read the paper. It's a relatively easy read in the scheme of things, and I think it lays things out fairly well and in a digestible, understandable way. But one of the things that the writing group agreed unanimously was critically important is that historical context be a part of the paper. And I am reminded that as a doc, when I was doing clinical care, when I saw a patient, it was critically important for me to understand how did the patient get to the place where they're at in the moment. It's called the history and physical exam. So you want to know about risk factors. You want to know about family history. You want to know about lifestyle. And it's really important not only to understand what's going on, but also to begin to appreciate what might be the strategies to address that thing which you're trying to take care of, whether it's high blood pressure, diabetes, early cancer. Really important to know why it got there and what is the context for dealing with it. So we felt the same way about historical context as it related to this thesis that we were going to lay out, that structural racism is a fundamental driver of health disparities. I don't want you to believe that we only talked about the historical context for Black persons in the United States. We actually capture, to the degree that we can, this is not meant to be a history lesson as much as just sort of laying the groundwork for understanding the African-American experience historically, that of American Indian, Alaska Natives, the indigenous people of the continental United States, the experience of Latinos, which is interesting and complicated, as the others are, and also the historical context of persons who self-identify as Asian, Pacific Islander. But I want to focus here because I think this captures so much of what's happened and helps us understand. And where I want you to start is in the center, where what is actually there are what we sometimes talk about being the social determinants of health: poor access to health care, poor housing conditions and physical environments, poorly funded schools, poor access to capital. We could add food insecurity as another thing we talk about a lot as being a social determinant of health. But if you started going upstream, as we did, where let me just go again and say to you, we got to this place as an organization because we started with cardiovascular and stroke outcomes. Think of it as at the bottom or at the end of the stream. We walked our way up and understood that there were risk factors that contributed to those. Then we walked our way up the stream, if you will, and then we came to social determinants of health. And as we have looked further upstream and tried to figure out what is contributing to these social determinants of health, we can't help but conclude that the historical legacy related with the experience of Black persons in the United States explains a lot of it. And Jim Crow laws that segregated and redlined persons, particularly Black, but it had similar effects on many other non-white persons in the United States, and racial bias in the justice system all contributed to a concentration of poverty and this disproportionality of social determinants of health that Tanya captured in the wealth gap. And I do want you to think about this. In Tulsa, it is possible that the wealth gap between white persons and white families and Black families was a certain amount. And I guarantee you that a month after the Tulsa massacre, that wealth gap was wider, and the ability to close that gap was made more difficult because poverty was concentrated, and the access to the things that had closed that gap, the ability to have access to capital. There were banks, there were stores, there were barbershops, there were, I think, 3 movie theaters in this small community. It was a self-sustaining community. All of that got taken away. The wealth gap grew. And the one thing that I'll say is that perhaps people don't appreciate that things like the GI Bill and things like the GI Bill, which did 2 things, among other things. It supposedly afforded many folks the opportunity to go to college. Well, that opportunity was mostly realized by white persons in the United States, because if you were Black, the ability to get those loans, those scholarships were lessened. The ability to get into a school that would accept you because you were Black were low. The ability of historically Black colleges and universities to absorb the demand was very, very challenging. And then on the other hand, there were loan programs to make it possible for people to buy homes. And again, those loans were preferentially favorable to persons who were white and preferentially unfavorable to persons who were Black. Again, contributing to concentrated poverty over several decades. So back to you, Tanya.
And before we move, I know we're going to head to the next slide, but let's, Ariane, keep this slide up, because I think Anita's question that just came in is best answered, perhaps, Eduardo, while this slide is still up. She's obviously looked at it quite carefully, and she's wondering about access to healthcare as a determinant of these inequities. She's specifically not seeing access to vaccines or access to clinical trials, and asks whether or not that's a key determinant. And let me just, as a reminder, say most of our audience is employers. Employers often, from a proportionality standpoint, assume that because they have health benefits, that's sort of their biggest sphere of influence. Could you talk about that in the context of what you also said, food insecurity, livable wage issues, housing issues? What is AHA's take on where employers can pitch in this diagram?
So let me start with the access to healthcare issue. So the one set of good things that happened, because let me be clear, there has been progress that continues to be made. We just have room to do more. And one of the things that did happen was in 1965, the legislation that created particularly Medicare and Medicaid afforded people, Black people, white people, Latino people, and others, access to healthcare, not uniformly, but a significant improvement of where we were, and some gaps were closed, particularly among the elderly. And oh, by the way, some would say that Medicare not only provided access to medical care, but also was an anti-poverty program. It helped reduce the challenge that many families had in trying to pay for healthcare when they just didn't have the money to do so. And then Medicaid afforded many access to healthcare, but Medicaid, even before the Affordable Care Act, was not evenly distributed up by state. So states that are in what is the kind of the old South were states that even before the Affordable Care Act had a differentially low participation level, and many Black persons, Hispanic persons, and others were disproportionately uninsured in those states even before the Affordable Care Act. The Affordable Care Act has helped close that gap somewhat. Now, access to clinical trials, that is a remnant of not only what we're talking about here, not only the way healthcare works, but also the way in which persons are recruited to be parts of clinical trials on the one hand, and their lived experience with healthcare. So Black persons in particular have had and actually African-American persons and American Indian Alaska Natives in this country have had a very rocky relationship with what are experiments done on people. And up until about 50 years ago, too often, people were in clinical trials without their knowledge, without their consent. And what happened in Tuskegee resulted in what are now very accepted norms about informing people, getting permission from people, but the legacy of distrust has been very, very hard to overcome. Last thing in terms of employers. Employers, think about those of you on the call. Think about the statistic I showed you about blood pressure control. Not having insurance lowers the likelihood of blood pressure control almost by 50%. And not having seen a doctor in a year, which is a proxy for not having insurance, lowers it even more. So the role that employers can play, in my opinion, is to advocate for any and all things that increase health insurance for more people. And if you are in states like I am in Texas, and I just was reached out to by an advocate to raise my voice, an opportunity that we have to say it is really important that this state expand Medicaid so that we can close those gaps related to access to healthcare that are related to this historical legacy of Jim Crow laws and the concentration of poverty and the things that come as a result.
Thanks, Eduardo. The other thing I would just add is right after we started to notice the disparate impact of COVID-19 on Black and Latino communities, I moderated a webinar for the American Heart Association on the impact. We separated them. So we did the impact on the Black community, we did the impact on Latino communities. And one of the things that came up from one of the researchers and doctors was also this bias of care. So even before getting to a clinical trial, you know, one of the doctors was talking about getting people, this is in terms of before we knew what the vaccination rollout would be, to sort of think about their experiences with care and the bias they might have experienced with care. And one of the things I've seen employers do, two things during the pandemic. One is to acknowledge the need to also have access to a diversity of healthcare providers. I've seen this more now in the mental health space, particularly in the tech community, where they've used apps and things to let people get access to mental health practitioners outside of their specific area. I've never seen such an attention and focus on this, and just an awareness of getting people. I can tell you a client that I have here in New York City made it a point, have the Latino ERG, Employee Resource Group, bring in someone to talk to that group about the impact on different communities and educating different communities. So I think it's that relationship and connections that can help. Next slide. As we come to the end, we just wanted to focus on a couple of more things before we open it up to questions. One is the thing that the structural advisory, the presidential advisory wanted to address were these things you have here on the slide. And I think just looking at, and this answers in some way the question, so to think about and acknowledge historically marginalized communities, but also restructuring the systems, which gets to that structural piece I talked about. And then the policy piece, right? Implement policies to improve education, housing, neighborhoods, especially in residentially segregated neighbor areas. And then also just to do all the things we've talked about. I mean, at American Heart Association, I've been on several committees and many meetings looking at the inequities in terms of access to quality of healthcare. I mean, Eduardo can talk more about this, but we're talking about pharmacy deserts. We're talking about in rural communities, what it might take to get to see a doctor, or an absence of a transportation system that might get someone to get that care. So Eduardo, the next slide is you and then me, and then we're going to open it up to questions.
So one of the things that we also addressed in the structural racism paper is this notion of allyship, that too often when we're talking about these issues where one group is disproportionately affected adversely, we sometimes expect that that group that's being adversely affected is going to be the lead and the only kind of voice for change. And it's very clear that when one thinks about the things that happened during civil rights, that allyship does play a role. And those of us, however we define ourselves, who can lend a hand, who can understand, who can be part of the voice for change, but also the voice or the ears to hear and listen. That notion of allyship is something that we felt needed to be addressed. And as the organization that is the second largest funder of cardiovascular disease and stroke research in the country, we're a very far away second, but we are number two. No one's close to us. We are behind the National Institutes of Health. We felt that it was really, really important that we make a statement about research on racism and its effect on health, as well as taking a stand on anti-racism to inform that research. And what I mean by that is back to the comment made by Tanya about people looking like people when they are providing care. We believe that people need to have the lived experience of people to be involved in developing the research designs and asking the research questions that will result in the insights we need to eliminate the disparities that I talked about very early in the discussion that we were having or are having today. So back to you, Tanya.
Yeah, I actually think this next one is you before me, Eduardo. So this next one is about the 10 commitments and the AHA focus areas. Okay,
well, you gave me a gift. I think the last slide was yours, but that's okay. We're like brother and sister. So the one thing that I do want to say is this call to action. Sometimes call to actions are very externalized. It's y'all need to do this. But this call to action is one where we are doing some introspection. And so it's both internal and external. And our strategies are around leadership. So we have been involved in being a voice for this issue outside of ourselves, convening discussions, convening meetings. We are in the space of trying to inform that science, and the two combined, we convened a meeting of funders of research to engage in the conversation about what will it take to close the gaps that need to be closed around health equity research and racism research. We have taken a lead in taking our quality improvement programs internally and making sure that we are not only capturing the data that would help us understand what disparities still exist, but also a commitment to close those disparities, eliminate those disparities once we begin being able to specify what they are. We want to make sure that as a business, we're a very large organization, we are doing business not only with historically underserved businesses, but you will find that in the paper, we actually call out the notion of not doing business with some organizations that maybe take a very a negative stance compared to where we would like to be. I'll be as positive as I can be. And then advocacy. I mentioned expanding Medicaid. That's not the only place. I will tell you that with regard to advocacy around COVID-19, we have been among the voices, not only for the messaging around COVID-19 vaccine, but making sure that we don't blame groups for being quote unquote vaccine hesitant when what's really going on is that we are not delivering vaccine to people where it needs to be delivered so that they take up the vaccine. And I'm heartened by the fact that those strategies, bringing vaccine to neighborhoods, using credible messengers just to afford people the information they need to make good choices, is resulting in gaps closing and more people across the board getting vaccinated. This wasn't COVID-19, but in a way it was accentuated, accelerated, catalyzed by. So of course we're back to that. Next slide. And I think this is the last slide, is that part of what the American Heart Association has also done is that it has made 10 commitments to achieve our 2024 impact goal, which quite frankly is to be, just put quite succinctly, a champion for health equity, and looking at just a handful of measures to determine that. But we've made 10 commitments. Some of them I've articulated already. The commitment to do, actually we're committing $100 million to science, to research. We are committed, we are part of a $100 million effort to improve blood pressure control among the uninsured and among those who are disproportionately affected by lack of blood pressure control. I described those populations. That's in partnership with government. But commitment number 7 is a commitment that we've made around health equity and employers. The American Heart Association has convened a CEO roundtable that's been in existence for 8 years now. It is made up of 50 or so Fortune 500 companies, mostly Fortune 100 companies. And I'm just going to read this. We're going to collaborate with our CEO roundtable to architect a roadmap, a conceptual framework, and related tools for employers to identify and dismantle practices and policies in the workplace that contribute to structural racism and health inequities, all based on the presidential advisory that I talked about. We will collaborate with the Business Roundtable to launch this effort with a CEO broadcast in January 2021, which happened. And we are well on our way. As I described to you, the writing group and the paper and the review processes, we are very close to having a paper that we've written, a primer that captures the architecture, the conceptual framework, and the tools for review by external organizations as we prepare for a July publication of this primer that is a reflection of our 10 commitments. So I hope that HERO will be on the lookout for our health equity tool for employers.
Yeah, and there's a really good question in the chat box. There's one last slide, which actually connects to what Paul said in the very beginning, which just basically says, how can we look at all of this holistically? How can we look at the fact that the anti-Asian violence, which was talked about at Human Rights Watch in May of 2020, the American Association, Psychological Association, talking about living in a racism pandemic. And then some of the work that I've been doing and following around the world around gender and how this COVID-19 pandemic is already having a disparate impact on women, which we're talking about. And that all of these other things, I think, is full circle to this syndemic, multiple pandemics, the sort of downturn in the economy, who it impacted, unemployment, mental health services, which we actually talk about mental health in the paper that we wrote. And I think just looking at this and sort of naming some of the ways the structural issues are affecting both mental and physical health is really important. So there's a question in the chat box, maybe Paul, and it might be Eduardo, you want to start on?
Sure, I'm happy to. So it's such a great question. And probably all of y'all have heard of the U.S. Preventive Services Task Force, which informs what things should be done in clinical care settings that might counsel, screen, diagnose preventable conditions, and then doing something about them. Well, there is a companion task force, and it's the Community Preventive Services Task Force. And the Community Preventive Services Task Force has put together a set of recommendations around science-based recommendations around things that can be done to address lots of things. There is a section on addressing equity at the community level. And one of the things that I can do while Tanya's talking is maybe go find a link and put it in the chat box because it's a place to start. And when I have the opportunity to answer a question like this, I say, one, acknowledge that there's an opportunity to be addressed. Acknowledge that you should start where there is some foundation of knowledge and some descriptions of success, and use that to start the conversation. And then, Karen, I will say to you, be on the lookout for our primer, because I think it's going to have some very concrete advice about what can happen at multiple levels around this. And then internally, I think the conversation around racism, both interpersonal and personal versus structural, needs to be had at institutional levels. And I will just repeat that one thing that we're all interested in is diversifying the workforce itself and creating safe places for employees as well as patients.
Yeah,
and Eduardo, not everyone might have the questions open, so just a reminder that Eduardo was talking about what health systems can do to counter racism and communities, in addition to what they can do internally for their own folks. And we're going to keep questions going, but as I tee up the next question, first let me tee up a poll. Distrust in science generally and vaccines in particular are divided sharply along racial or caste or class lines. Now, how has your organization responded? As I wait for those answers, Tanya, you were quite clear early in your presentation to distinguish between discussions about individual racism and structural racism. You may have seen the Times article this morning about something of a backlash from the critical race theory movement that's happening in the schools. A lot of white people are feeling on their heels, as Eduardo suggested, getting our blood pressure up with the perception that critical race theory, or even these DEI programs that are exploding in the corporations, are asking the white people to step up and defend their race and whether or not they're racist. Could you reflect on how you would respond to people who are really, they're smart people, but they're profoundly against critical race theory as a belief that we're trying to rewrite history to make America look bad?
Yeah, I mean, so the person in me who sort of understands what fear is about, many of us have read maybe or seen Heather McGhee's The Sum of Us, right? This notion that it's a zero-sum game, that somehow if we're dividing the pie differently, if we're acknowledging that the pie was really divided in a way that impacted some of us to have more or have less, I think if that's the conversation, right? Are we looking at this from a zero-sum game? And I also think that respectfully, I think we need to understand what critical race theory really is versus what it's being said to be, what anti-racism is being said to be. And I think this goes to something we talk about around how do we really do some serious investigation versus just hearing what people are saying. Do I think it's hard to hear that we live and maybe have benefited from a system that's unfair? Sure, right? I mean, I think that's there. And here, as you see, the poll results are loading. So 40%, we acknowledge differences, but haven't tailored messages specifically to Black, Indigenous, and other people of color. 30%, not so far behind. We tailor communications differently to try to address hesitancy. And then 30%, we avoid any semblance of differentiation in communication for BIPOC people. I mean, I think we're on a journey. I don't think this is going to be the end of the backlash against anti-racism or critical race theory. For those of us who respect critical race theory, is to see it being really demonized when it really has provided some thoughtful and important analysis around the role of race and racism.
For our hero members on the call, we're looking forward to seeing them on Monday. We're doing a think tank all day. We're going to be talking about disinformation and the employer's role in trying to plug the rabbit hole. One of the elephants in the room that we're willing to acknowledge is that there are stark differences between Democrats and Republicans in what they believe and who they believe. So let's get a preview of the think tank for Monday by asking, distrust in science generally and vaccines in particular are sharply divided along political lines. At your organization, do you tailor messages differently about hesitancy for Republicans, or we acknowledge differences, but we haven't tailored messages according to ideology, or we avoid any semblance of partisan differentiation in communication? I'm going to go ahead and show that poll right away, Eduardo, and start with you as someone who resides in Texas and again has sharply divided views between you're all down there and the rest of the country, frankly. Most still in companies on this poll are avoiding any discussion that differentiates between ideology. What's your take on the opportunity or risk here?
So that's such a great question. And one of the things that the American Heart Association is always involved with is how does one move change in the direction that results in longer, healthier lives. And as it relates to the work that we've been doing around COVID-19 and the vaccine, we've partnered up with a gentleman named Frank Luntz. Some of y'all may know that name. Frank Luntz was or is a Republican pollster. That's how you would see him described, who will tell you that he suffered a stroke event about a year ago. And it changed his perception about things and changed what it is that he's been working on. And one of the things that he's done is he's partnered up with the De Beaumont Foundation, whose mission is about improving public health and public health institutions. And he has been working on the language for change among those who are hesitant to get vaccines. A code word for how do you get, and I don't mean to be offensive here, I think Frank Luntz would use this language, how do you How do you use language to change what white male Republicans, self-identified, have said is their reluctance to get vaccinated? And so I've been a part of these focus groups that are looking at what are the words that are trigger words in the negative, and what are the words that might cajole someone along. One of the conclusions, medical experts is one. Using the word government, not a good idea. The idea that you are doing this to return back to normalcy, as opposed to you're doing this for all of society. Frank Luntz would say those are some things. So rather than have different messages, we are finding the ones that will resonate with the most reluctant group and using our messaging to accentuate that language. One more insight is that that group can be swayed by their personal doctor. And you will recall that early in the vaccine campaign, it was all about going to the mass vaccine sites. Well, if you're somebody who's going to be moved by your doctor, that may be a disconnect. And so you will have seen more and more messages now that are saying, talk to your doctor, talk to your pharmacist. And what you may not know is that those have been informed by some of the Frank Luntz insights. And, it all boils down to things that I know Tanya has been saying and I've been saying. Message matters and messengers matter. And so I was part of I got to witness one of the focus groups that Frank Luntz did that included 3 Republican congressmen who are physicians, actually 2 congressmen and 1 senator. And I'll tell you what, they moved the needle because they were seen as trusted messengers. And the message they delivered was one that moved people along the continuum from hell no, pardon my language, to I'm really willing to think about it. So that's what we've done. Yeah. It's not a differential message, although I will close by saying one other thing is that we've been involved with the getvaccineanswers.org website, whose frame is not about convincing you to get vaccinated. Its frame is about getting you information to make a good informed decision. That's one other thing we've done is rather than tell people what to do, we're directing people to get better information.
Hey, we're running over a bit, but let me remind you that our participants are hanging in there and not dropping off. This usually would be at the end of the hour. So Tanya, I'm going to take an executive decision and give us just a little bit more time and let you weigh in just to wrap things up, especially as it relates to some of the comments you started to make about the differences employers and employees are experiencing in terms of receptivity to DEI. And as much as we're seeing it trending strongly in the nation, like critical race theory in our schools, I'm afraid we're also seeing some real polarities happening in corporations with some people just feeling like this is political correctness run amok. Why should I have to bring my whiteness and my race into discussions every day at the workplace? What do you say to the folks who are struggling here and wanting to be allies, but not wanting to be, in their view, subjected to again, defending their race?
Yeah, I mean, it's a big question. So I would say ally equals action, right? So there's some interesting work that was done by Deloitte called Everyday Bias. And it was done in, I think in 2019, and they looked at organizations, and the research suggests that if you could just Google it, Everyday Bias, that there were sort of people named that were dealing with this larger acts of bias, but not the everyday bias. And one of the things that came up in the data was that people said they were allies, but there was no action attached to it. And so I don't think we can say, I want to be an ally, but this is only the way I want to be an ally for this particular work. I also think, by the way, we need more white people doing this work. And I think that's something that a lot of us are talking about. So not just people of color coming in, not just those who've been historically marginalized, but actually white people who sort of have thought about these topics, who care about these topics. And there are white people who care about these topics. I think this sort of separation of who cares, whose issue is it, is some part of the challenge at times.
Yeah, thanks for that, Tanya. So Eduardo, to answer your call to action, I just think it probably goes without saying, but on behalf of Karen Mosley, HERO's president, she has just finished a long-range strategic plan with the HERO board, which has some of our American Heart Association colleagues on the board. And be assured that health and equity issues are front and center in a lot of the strategic planning that HERO is working on. So count us in as a partner for your call to action. And thank you today to Tanya Odom from Walton Family Foundation, Eduardo Sanchez from American Heart Association. We really appreciate your great work and leadership on this. Thanks a bunch.
Thank you for having us.
All right.
Thank you so much. Thank you, everyone.
Bye-bye.